morning, everyone. I want to welcome you to the Institute of Medicine of Chicago's session on tackling maternal health to achieve maternal health justice. This session is a part of our series of the 8th convening of the State of the Health of Chicago, and we're really happy to have you here today. I'm Cheryl Rucker-Whitaker, and I'm the president and chair of the Institute of Medicine of Chicago. And on behalf of the Board of Governors, it's my pleasure to welcome you warmly. I want to take a second to pay respect to our past board director, Dr. Leslie J. Sandlow, who passed away this summer, and thank him for his inspiration, his dedication, his commitment to the IOMC. His career spanned over 50 years, and he will be missed by me and many, many others. Today's topic is one that is very important to me as a physician, and it's important that the IOMC, as an independent organization of distinguished leaders in the health field, really collaborate to raise the level of conversation, dialogue, and education around these types of topics. And that's what our work is. So it's really unfathomable to have so many resources available, yet having so many women struggle to find the type of care that they need. So I thank you. Before we begin our session today, here are a few upcoming dates that I hope are on your calendar. Please add them. Dr. Melanie Dreyer, who's a Dean Emeritus from Rush School of Nursing and a fellow, an anthropologist by training, will moderate a session on cannabis, everything you need to know and be pain-free with CBD. So we're looking very excited about that. This is cutting edge now in medicine. We're finally able to talk about the cannabinoid receptors, and we want to follow the science, right? And learn as much as we possibly can to have the broadest set of offerings for people we take care of. On December 17th, the Institute is pleased to have with us Andy Slavitt, who was formerly CMS director. He worked in the White House with Biden on his transition for the COVID-19 response. And Andy will be talking about his book, Preventable, the inside story of how leadership failures, politics, and selfishness doom the US coronavirus response. Kind of some heavy talk while we also share a little holiday cheer. So we're excited to welcome Andy. So please join us for both of those. In 2022, we'll continue to be busy convening, educating, sharing. So in February, we'll address mental health trends, crises, and imperatives. In March, we'll be talking about homelessness. In April, we're partnering with Rosalind Franklin for a couple of sessions on intersectionality of education and community engagement. And in May, we're addressing chronic kidney disease and its resulting disparities. In June, we'll host the annual meeting. We hope that it'll be an in-person event. We're reserving a space now. We rolling over from last year and we're hopeful that we'll be in shape to do that. So we'll be addressing the opioid crisis at that meeting, among other key issues. If you have input as a fellow, please share. Check us out on LinkedIn, our blog, check the IOMC website for more details in the coming weeks. So let's return to today's session. Our agenda includes a highly detailed presentation by Dr. Melissa Simon, which will be followed by a Q&A. Feel free to stay on for a few minutes after. We're going to keep the webinar open from 1 to 1:30 for more kind of, interaction, dialogue, and maybe some problem solving, and even considering if there's a small group of us who want to work on this as a work group. So by attending today's session, you will learn the drivers of maternal health inequities, identify ways to advance maternal justice through implementation science, and obtain ways to advance maternal justice through clinical care practices. These are important points to keep in mind during the presentation. We are recording this presentation and it will be made available later on the website. This is an accredited program. Please complete the program survey to obtain your continuing education credit and your certificate. It will be available after the session. The speakers have completed financial disclosures and they are on file with Rush University. I want to thank our sponsors, Blue Cross Blue Shield of Illinois, Northwestern Medicine, Rosalind Franklin University, the University of Chicago Medicine, the Portis Foundation, the Michael Reese Research and Education Foundation, Washington Square Health Foundation, Hectone Institute, Complete Care Management Partners, Aunt Martha's Health and Wellness, Care Advisors, and Golden Square. Thank you to our sponsors. Now, it's my pleasure to introduce my friend and fellow colleague, Dr. Melissa Simon. Melissa is a professor of obstetrics and gynecology at the Feinberg School of Medicine at Northwestern. She's also heavily involved in directing the Center for Health Equity Transformation, the Cancer Health Equity Collaborative, and does extensive work out of the NIH. Her primary research interests are aimed at promoting health equity and eliminating health disparities among low-income, medically underserved women across the lifespan. She integrates health services research with socio-epidemiologic models to sort of drive that work. Her research focuses on interventions such as patient navigation and community health outreach workers that aim to reduce health disparities. And Dr. Simon, you know, I could go on and on your resume here, so I apologize that we didn't read the entire thing. It's super amazing, and you're wonderful, I know, mother of 4, and you managed to do all this important work. So we're super duper, one, proud of you, glad to know you, and just amazingly happy to have you here today. So thanks for joining us, Dr. Simon.
Thank you. Thank you, Dr. Wicker. Such a pleasure to be here. Thank you so much. All right, everybody. Thank you for sharing your Friday afternoon with me. I have nothing to disclose, but I am an immediate past member of the United States Preventive Services Task Force. So I always have to say that this content does not necessarily reflect the views of the USPSTF. So 3 main points, because some of you may have to drop off early. Women, and especially Black and Indigenous and Latinx women, have been historically maltreated in healthcare and research in this country. We in research and healthcare delivery have earned the distrust of our Black, Indigenous, and Latinx patients, and now we have to work even harder to earn that trust back. Racism and not race is the risk factor. Maternal mortality and other maternal health inequities are completely egregious, especially in the United States of America, and can and need to be eradicated. So definitions, all right, inequality. So up in the upper left-hand corner. So just because it's a picture of trees doesn't mean that everything that's built is, that I'm assuming is naturally occurring. These tend to be structures that we imposed over centuries and decades. So I'm just using the tree as like a symbol to help make a point. So inequality means that the tree, which could be a policy, practice, any kind of thing, is bent towards one population or set of people, and actively advantages that group of people by the apples naturally falling to them, and actively disadvantages the other people or populations on the other side of that tree. In the upper right-hand corner, equality is such that we say, oh, everything's equal, we're fine, right? That means everybody has the same lift or ladder, if I may, to reach the tree and try to get an apple. But again, even in the equality model, some populations are actively advantaged and some populations are still actively disadvantaged. In the lower left-hand corner, in an equity model, and that's why we use the word health equity, we acknowledge that everybody requires a different kind of lift, could be a different size ladder, different material, whatever, to get to the apple, the intended outcome of a policy or practice, etc. In this case, the apple, to benefit, right? And then really where my work and where all of our, especially leaders' work, needs to go is the justice framing. The justice framing asks the really important questions. Why is the tree bent in the first place? How do we unbend the tree? Or if the tree is totally rotten, how do we get rid of it and build a new tree? Okay, so that's the fundamental important framing here for everything we do in health equity work. So we need to work to unbend the tree or realize we need to plant a new one. So we really have to ask the right questions, right? You can build a widget, right? But the widget may not help whatever it is that you're trying to help unless you ask the right questions at the get-go. That's really what this is about. Racism is a fundamental cause of disease. It's baked into our system and institutions, and it kills. Dr. Kamara Jones, one of my sheroes, she says racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities and saps the strength of the whole society through a waste of human resources. The National Academy of Medicine in 2017 published a Communities in Action report that really shows where like the social determinants of health, which are those infographic pictures around the middle circle, and then really trying to create community-driven solutions and really address structural inequities and systemic racism, because it's the racism that's driving the inadequate social and economic factors that contribute to health, right? So it's not social determinants of health driving health. It's the racism and the root causes more upstream, and the policies and practices that are having bent trees, so to speak, that drive social and economic and political factors that are negative towards, that impact health outcomes in negative ways. Another way to look at this is how discrimination affects health and gets under our skin. David Williams out of Harvard has a publication in 2019 in Health Services Research that kind of shows really nicely how the house that racism built. And basically in the basement, the bottom square rectangle of that house, you've got individual discrimination, and that experience impacts psychological responses, biological processes in the immune system, behavioral responses, healthcare use responses, and individual and collective responses that impact health outcomes. So we have a deep and long history in this country that you have heard before, especially over this last year, of slavery, racism, and discrimination. We've treated people as property in the research realm. You know, back in the 1800s, even in places like South Carolina Medical College, points out how enslaved people are used for medical research and how that's an advantage to their institution to come there so that people can research on enslaved people. Gynecology and obstetrics is definitely has a very dark history with J. Marion Sims, who is considered the father of American gynecology. He did vesicovaginal and rectovaginal fistula and actually has instruments named after him. He experimented on 12 enslaved women, including Lucy and Arkham Betsy, without anesthesia, and did this over and over again to perfect the procedures. His statue was taken down in Central Park last year. Those are pictures on the bottom of the screen. Eugenics and colonialism is rampant. It has been rampant around the country. In 1917, there were Bath riots whereby we had Mexicans crossing the border, but they couldn't cross the border to do work in our country unless they were disinfected with things like vinegar, kerosene, and gasoline. In 1917, Carmelita Torres, who was 17, she refused to get off the bus and submit to this disinfection process. In Puerto Rico, the women were enrolled without their knowledge in contraceptive trials in the 1950s, and Ovid being the first birth control pill. And thanks to the Puerto Rican women, it was investigated, but they were not, it was trialed, but they did not know they were in the trial. There was forced sterilization in the 70s. And that continued even today to force hysterectomies. We know this from last year's reports from the Georgia and ICE detention centers. And despite even in the 1950s in the New York Times, where it says no scientific basis for race, a whole very expert panel concluded this, we still to this day have issues around false beliefs in the medical profession with around pain, things like pain, biological differences between Black and white patients, the false belief that Black people have thicker skin than white people. And this plays out on the labor floor with who gets offered pain medicine at what frequency, who gets offered epidurals, things like that. health is impacted by everything. Even in Chicago, we have the school to prison pipeline. We have remnants of persistent segregation laws that persist to today. And that's how we got here, right? And so we just have to keep plunging forward. And my favorite scene from Hidden Figures, I have to put this in, when Kevin Costner breaks down that bathroom sign and says, "We all pee the same color." That's the best biology I can offer, except if you're on like a, certain medication or have some certain conditions, we really do all pee the same color. So to women's health and maternal health, women's health has across every part of women's health, there are racial ethnic disparities. You name it, it's on this list, plus many more. But with respect to maternal mortality, it's actually a sentinel public health indicator. It's one of the few measures that are included in the United Nations Sustainable Health Goals. And the United States has the highest maternal mortality rate of any high resource country. And it is the only high resource country and one of about 9 countries in the world with rising rates. So we share this claim to fame, so-called, with countries like Afghanistan and Sudan. And maternal disparities, again, this is the maternal mortality ratio from 1987 to 2013. And even to 2018, we've got 17.4 deaths per 100,000 live births per year. And there are considerable racial ethnic disparities, with 12.1 deaths per 100,000 live births for white women and 40.4 deaths per 100,000 live births for Black women. Completely egregious. If you compare these rates to other countries, so the top states are the bottom left-hand corner where the circle is: Georgia, Louisiana, Indiana, New Jersey, Arkansas, Texas. Right? They have the highest maternal mortality rates in the country. They flip in numbers 1, 2, and 3 a little bit, but compare that over to the right, where you've got some country maternal mortality rates by country. Iraq is about 50 maternal deaths per 100,000 live births. Georgia, Louisiana, around 45. That's ridiculous. It's unacceptable. Infant mortality is no better if you compare the United States, which is on the top, green, to the rest of the developed, to the rest of industrialized or wealthier countries. We're the worst. And then if you look at the data disaggregated by race, it's even worse. So the Black women, the Black baby rate is on the red line, 11.6, and it's the trends are steady beyond 2010, and then white infant mortality ratio being 5.2. So for Illinois, our most recent data were released for maternal mortality in April of this year. We know that in general, about half of all births in Illinois are to non-Hispanic white women, about 21% are to Hispanic women, and about 17% to non-Hispanic Black, and 8% to non-Hispanic other races. And about 75 women die each year while pregnant or within 1 year of pregnancy. So that's about a death every 5 days. All right. We need to value our people who carry our next generation, who birth our next generation forward. And these data clearly reflect that we don't. About half the deaths occur during pregnancy and up to about 42 days postpartum. So what's important, though, is that entire year, the rest of those deaths occur between days 42 postpartum and 365 days postpartum. So about half the deaths occur, maternal deaths attributed to pregnancy occur in that first year postpartum. And so I'm thankful to say that Illinois is one of the very few states who have, at least on the books, included the postpartum period up to 1 year. Mental health conditions, including substance use disorders and opioids overdose, are leading causes of pregnancy-related deaths. And more than 4 out of 5 of the pregnancy-related deaths are actually preventable. 4 out of 5 of them. Black women are about 3 times as likely to die from a pregnancy-related condition as white women. Black women are also more likely to die from medical conditions. All right, white women are more likely to die from pregnancy-related mental health conditions, including substance use and opioid disorder. So specifically for Chicago, non-Hispanic Black women have the highest rates of severe maternal morbidity, which is on your left-hand side of your screen, with the navy blue-ish bar being the non-Hispanic Black rates of severe maternal morbidity per 10,000 deliveries. On the right side of the screen is maternal mortality per 100,000 births. And again, the bluish bar on the screen is non-Hispanic Black women versus all others. So socioeconomic, structural, and policy factors. So the tip of the iceberg is what you see, that phenotype, the disparities in birth outcomes amongst the infants and also the mothers, the women. And you've got all of these things under the ice, under the water that actually drive birth outcomes, including racism, graduation rates, housing rates, employment, school to prison pipeline, everything I talked about earlier. An interesting study, and more work is being done in this area, but hypersegregation and disparities in preterm birth, this is kind of a landmark article that really helped spawn more of this work of, social deprivation index and neighborhood factors contributing to birth outcomes. And basically this shows the dotted line is racial disparity in non-segregated metropolitan areas, and the solid line is racial disparity in hyper-segregated metropolitan areas. And basically it shows that the more hyper-segregated of an area you live in, and Chicago is one of the most segregated cities in the country, the worse your outcomes are in preterm birth, the more likely you are to have a preterm birth. COVID-19 has exposed existing health inequities and exacerbated them across the board. In addition to that, so we have pandemics of COVID-19, racism, and disinformation, which is promulgating issues with vaccine uptake for sure. And what COVID's done is really make these two different cliffs, or these two different cities that we have in Chicago, very separate. And so we've got the orange, yellow people who are further away from the edge of the cliff. They have the safety fence to prevent them from falling. They have a safety net in case they fall through the fence, and they have a functioning ambulance with a GPS that works and gas in the tank and tires that aren't popped. But there's none of those supports on the cliff where the green people are, and they start closer to the edge of the cliff, which makes it even worse. So racial and ethnic inequities are caused by society, structural and institutional racism, not directly by genes. There's no pathophysiological differences between racial groups, and racism is the mechanism by which racial categorizations have biological consequences. Explanations for disproportionate rates of COVID-19 in Black, Latinx, Indigenous, and other communities of color mistakenly point to innate racial differences instead of longstanding institutionalized racism and other underlying social, structural, environment, and legal factors. And that's really important because we saw in the beginning of this pandemic some egregious publications in high impact journals, medical journals. And again, this is starting to come out and improve. But again, we always need to read journals and research with that kind of a lens. Genetic risk factors, epigenetics, environmental factors may contribute to severity of COVID-19, but race or ethnic group is a poor proxy to understand the population distribution of such risk factors. And so we can't ignore racism, and we really need to understand what we mean when we use race in our studies. We also understand that racism exposes people more to people of color, more to COVID-19, and protects them less than their white counterparts. Black, Latinx, Indigenous people make up more frontline worker positions, as we know. There's poor access to information and education. There are greater proportions of us unhoused, doubled up, or in prison, jails, or immigration detention centers. And then we're more likely to die when we care, and we carry a greater burden of chronic disease from living in disinvested communities. You know, again, the segregation laws, and then less access to healthcare in the case of COVID-19, less access to testing and vaccination sites, et cetera. And then there were workforce protection violations that were egregious, especially in the beginning of the pandemic, in meat processing factories, for example. That intersectionality of female, pregnant, augment oppression and compound racism's effects. So COVID-19 basically made a bad situation even worse, especially for Black, Indigenous, and Latinx pregnant persons. It exacerbated the social determinants of health across communities that were already marginalized, disinvested, and under-resourced. So if you look at pregnancy and COVID-19 CDC, between January of 2020 to October 4th of this year, there were 127,193 cases in the United States documented, and 171 total deaths for pregnant persons in the United States. And of the data that were available, only out of the 111,199 women that had racial ethnic data, and that's another issue through this pandemic from a science lens, is that the data attributed to pregnancy and data attributed to racial ethnicity are limited and not always accurate. So about 38% of women who had COVID and were hospitalized were Latinx, and about 13.6% of women were Black, and about 38.8% of women were white. In terms of the need right now, where we're at in the pandemic, is the need for pregnant women to get vaccinated. It is clear that it is safe in pregnancy. As of September 29th, the CDC data showed only 31% of pregnant people having been vaccinated for COVID-19. That's terrible. About 15.6% Black, 25% Latinx, and 45.7% Asian pregnant people were vaccinated. And really the benefits of vaccine for both pregnant persons and their fetus or infant outweigh the potential risks. And the CDC really has been pushing for health departments and clinicians to educate pregnant people about the benefits of vaccination. So the other thing to really consider in this, with respect to women in particular, is that our unemployment rates are much higher than at any point than since the Great Depression. For Black women, the unemployment rate is about 17%, Latinx women 19.5%, and white women 11.9%. And those who remain employed are frontline workers, which expose them more to COVID. And if they're pregnant, it makes it worse, right? So we've got also a reduced use and reduced access to pre and postnatal care during COVID. We had the changing, ever-changing, and very quickly changing hospital policies of visitor restriction during labor and birth. And as we know, that puts extra pressure, especially on women of color who can't bring a doula in or a support person, especially in the beginning of the pregnancy. Sometimes they couldn't bring anyone in. And if they had COVID, they couldn't have their partner, the baby's father in the room, or any person in the room with them. That put lots of limits and fear in labor and birth, and it should never be a fearful process at all. I think we all can agree with that. Telehealth options, while great, were not optimal for everybody who didn't have access. The digital divide was seriously widened, and so we need to be mindful as we go forward with that. Intimate partner violence increased, and then depression, anxiety, suicide ideation, and suicide also increased. Again, like I said, the limited social support, especially during pregnancy, was really, and labor and delivery, was very pronounced. We really, coming out of this pandemic, we really have to take a broader perspective beyond pregnancy, birth, and early childhood to really understand the essential role, that privilege of being able to take control over when someone decides to be pregnant is imparted to some people over others. That tree is bent towards access of access to comprehensive contraception, and ability to choose and plan pregnancy for some versus others. So it's a really important point as we move forward. So birth justice recognizes that all people can birth and be parents. It's a movement led by Black women and women of color, and it seeks to recognize these inequalities and to empower people in these communities in the pregnancy and birthing process. The birth justice movement works to safeguard the rights of birthing people to make decisions around their pregnancy, including seeking abortions, and to have children in safe and supportive environments. And there's a lot of national organizations advancing that work and that framing. Nothing is natural or inevitable about these inequities, so let's transition to some potential solutions. So this is a social ecological model to try to frame how to address disparities. Now, you have the innermost circle, which is the interpersonal barriers, right? There's health seeking behaviorals, health literacy, fear, distrust, lack of knowledge, right? So things like home visits, doula support, community health workers, patient navigators. Those are the types of interventions that help with those interpersonal barriers. In addition to that, in the clinic setting, trying to really figure out how healthcare clinicians and that whole clinical care team can engender trust. It's really, really essential to figure out how to better frame and engender trust in your clinical care practice. And that can be mild or moderate tweaks in the way you approach people, the way your clinic feels, the waiting room, how it feels, how your front desk staff and whole clinical care team welcome a patient and make them feel comfortable and really hear them out. One thing that was really apparent as a perinatal care provider myself is that we dump a very large amount of information onto a pregnant person's lap that first prenatal care visit. And why do we have to do that the first visit? And why does the first visit have to be 4 weeks spaced out to the second visit? And so rethinking how we deliver routine prenatal care is essential. All right. Another part of that individual interpersonal thing is understanding that now in the state of Illinois, postpartum period is up to 1 year. So it's not about getting a patient back for her postpartum visit 6 weeks after birth. There's should be a 2-week safety check-in. Make sure everything's all right. How you doing? How's your mood? How are you being supported? What can we do for you? Right. And then a 6-week, physical exam, everything okay, further checkup, but then not to release a woman out into, the wilderness, so to speak, and without thought about the fact that, half of maternal deaths happen beyond that 6 weeks. Half. Right? So imagine what we could do if we actually implemented the law. So things to think about. So nested within the interpersonal barriers is the next circle, the community. What can we do to really support community resources and organizations that are doing a great job, right? How do we do a better job of connecting community resources to our patients and women? How do we connect them better to healthcare systems, especially since we know that community organizations are the ones that operationalize the work that's needed to address social and economic determinants of health, right? It's not Northwestern medicine helping food insecurity directly, right? It's Northwestern medicine, for example, referring somebody to a place that can help with food insecurity or housing instability, right? How do we do that? And that connects to the next circle, which is the health systems barriers, right? Are we making sure that our AIM safety bundles and, for postpartum hemorrhage and hypertension, high blood pressure, preeclampsia, all of those things are attended to and addressed in a consistent way, no matter what the zip code of your hospital is and no matter what the zip code of where the patient comes from. Your zip code should not determine the outcome of whether or not you're going to die during childbirth or postpartum or perinatal. Absolutely not. And so we need to think about the quality of care. It shouldn't matter if you're next to Neiman Marcus downtown or if you're on the far south side. It should not matter. The Ames bundles, the consistency and quality of care should be the same. And then finally, the policy world is super important with respect to figuring out how things like reimbursement work, incentives, how we're funding consistent programs, not just for pregnant and birthing persons, but what about contraception? What about having that access? So all of those things that's the general framework, right? Thinking to unbend the tree or to plant a whole new tree in the first place. Let's start with a little bit on research, because I'm a scientist. I would be remiss not to mention a little bit about research, right? And towards best research practices. Thankfully, NIH is really moving forward with trying to bring together more diverse scientists and scholars to develop best practices in genetic, clinical, and social scientific studies for characterizing human genetic diversity, guidance for using racial categories to study racism's impact on health. They're doing more diversity initiatives with respect to their Unite initiative, and they're funding more health inequities work. And then guidelines for federally funded science should also include best practices for integration of biological, social, structural, environmental health determinants into the study of health and disease. Research justice is a framework that's starting to gain some momentum, and that really is a framework that seeks to achieve self-determination for minoritized and marginalized communities, more centralizing community voices and leadership in an effort to facilitate more lasting change from research, and not like the helicopter approach of the helicopter going into the neighborhood that's minoritized and then helicoptering out and then going on to the next study. Research justice is achieved when minoritized and marginalized communities are recognized as experts and reclaim and own and wield all forms of knowledge and information. So there's a couple of examples from my research team at the Center for Health Equity Transformation at Northwestern that we have recently started. One is the Optimize study. So what that does is we asked the important question of why is prenatal care not working for all women? And the answer was prenatal care, actually the routine prenatal care has never been tested outside of group care. And thus it's truly not working for Black women as opposed to white women. So what we're doing is centering Black pregnant and birthing persons in there and their clinical care teams, and trying to get where we've taken the first 2 years to literally detail the experiences of Black and pregnant birthing persons and their clinical care team providers, and then feed it back into the clinics. Right now, we're working with Alliance Chicago and Access Community Health Network clinics across the Chicago area, and we've created an intervention, and we're doing a randomized cluster clinical trial, implementation trial, to really figure out if the new or updated model or approach to perinatal care can help improve Black women's and Black pregnant and birthing persons' experiences of care and also outcomes. Another example, we just received funding from the National Institute of Minority Health and Health Disparities from NIH. The Well Mama Doula Project is a partnership with Stroger-Cook County hospitals in Baton Rouge, Louisiana, and in Newark, New Jersey. Again, some of the places in the country where there's high maternal mortality rates. We're also partnering with the Perinatal Care Quality Collaboratives in Illinois, Louisiana, and New Jersey. And the purpose is to develop and evaluate an intervention aimed, again, focused on BIPOC individuals, so Black, Indigenous, and people of color who are pregnant or birthing, and then postpartum. And it's centered around community doula navigators, and both in telehealth and in-person methods, and check-ins regarding the 5 priority areas, which are really aligned with maternal mortality, the highest rates of severe maternal morbidity and mortality in terms of mental health, opioid substance abuse, cardiovascular symptoms, safety, and social support. So multi-level approaches are required. We really do have to engage key national, state, local, community serving organizations as an essential part of the response to really improve health justice for pregnant and birthing mothers and health systems across cities. You know, during the pandemic, the Mayor's Racial Equity Response Team Provider Group was actually a great example of when the city can actually, all the health systems, community hospitals, and community health clinics can actually get together and work together on a weekly or bi-weekly basis and get something done. We were able to make a statement across the city. We were able to move forward with a health equity dashboard of the sorts, and that's still going on, being created and tested. But, you know, it can be done, and it actually needs to be done with respect to maternal inequities. You know, transparent, equal partnerships with community leaders and organizations are important. So, you know, at the state level, the state has an obligation to uphold a right to health, right, and redress racial inequality within this right. And, you know, it's important to identify government and other targets for advocacy and intervention. And this is really a human rights framing. Accountability is situated within an intersectional reproductive justice framework. And so if you ascribe to this, then really some of the questions that you would ask is, what are state level policies and institutional factors that contribute to practices and pathways associated with poor health outcomes, including the maternal deaths, and why Black women experience such disproportional risk during pregnancy, childbirth, postpartum compared to white women? And those are the important questions to ask as a health systems level leader and as a state level policy. And so thankfully, again, in Illinois, with the 1 year postpartum definition, that helps us move forward with then more granular applications or implementation of that law. So other strategies legislatively, as well as policies and practices at state level that we can use to lower maternal deaths overall. And really our Illinois Perinatal Care Quality Collaborative is phenomenal. It's one of the models for the nation. And they're really, they've have over 99% of all hospitals across Illinois actually working on at least one of their many initiatives, including the MNO initiative, which is the maternal neonatal opioid initiative, because opioid overdose is one of the highest reasons for maternal mortality in our state. The National Framework for State Accountability, access to and quality of care is important. Insurance access, pricing, reimbursement models that I know Dr. Rucker-Whitaker is hot on, funding for maternal health in general, and accountability around data analysis use, specifically with regards to states' maternal mortality review committees. So again, with respect to the first one, the access to and quality of care, you know, it's important to have, you know, really look at the delays related to insufficient distribution of information, care, services, attitudes and practices at local, municipal, and state levels. You know, there's a 3 delays model that many people talk about nationally, that outcomes result in health deficits. So for example, when deciding to seek care, prenatal care is important, but there's a delay, right? 1 in 5 to 1 in 4 women of color do not start prenatal care in the first trimester. And this is even worse over the COVID pandemic, right? And distrust, lack of information, fear, all of that promulgates this delay. When attempting to reach adequate healthcare facilities, about half of all births are Medicaid funded. Really, it's about 43% in the United States. Medicaid reimbursement is woefully low and cumbersome, right? And that disincentivizes providers, right? The other important note is that crisis pregnancy centers, which are, they try to prevent you from getting an abortion, receive taxpayer funds. And this is a bigger issue in more red states, but again, it's an issue. And rurality, being rural, is a big factor, with about 80% of people living in rural areas needing to travel extensively to get care. And when receiving care, racism, discrimination, and bias, that promulgates more delay. You feel undervalued, disrespected, unheard, discriminated against, and doulas, midwives, birthing centers are not widely available across the state, let alone the country. Insurance access and pricing policy decisions, right? The consistency of coverage, high uninsurance rates. Remember, insurance is tied with employment oftentimes across this country, and COVID has ravaged unemployment rates, right? And so now we've got higher uninsurance rates since COVID. So coming out of this pandemic, we need to have that in mind. Coverage gaps also are a big deal. And then funding for maternal health is subpar, but that also includes family planning and comprehensive contraception access. So funds flow is a big issue, and availability of things like family planning options, and Texas is a great recent example, subpar. This is unacceptable, right? Other policy considerations, health insurance, I already said some of these, but now more than ever, since we know that up to 50% of maternal deaths occur up to 1 year post-birth, extending that Medicaid coverage that we have in Illinois for up to 1 year could help mitigate many health inequities and improve follow-up. But we have to be strategic in the implementation. And so how do you set up reimbursement models for continued postnatal surveillance up to 1 year? That needs to be emphasized with reimbursement and things like around follow-ups for hypertension, high blood pressure, diabetes, contraception, anything. Mental health being a huge one as well. And then the wraparound services, that continued need to support social and economic factors doesn't just drop off at week 6 postpartum, it continues. And some people would say it increases. In terms of data and state level maternal mortality review committees, again, our state's great. The Illinois Maternal Mortality Review Committee is great. But not all states have the same definition of maternal mortality yet in this country. Some stop at 42 days and some stop at 364 days postpartum. And so we need to have a countrywide consistent definition of maternal mortality. Again, a shout out to our Perinatal Care Quality Collaborative. Illinois is a great model, and Dr. Ann Borders leads that and should be applauded for her efforts and that team's efforts. Boosting resources to doula and other perinatal care support services like lactation counselors and childbirth educators, home visits postpartum, and then increasing workforce development. We need more Black, Latinx, and Indigenous clinicians, including OBGYNs for sure, but also for sure midwives and doulas and nurses, nurse practitioners, et cetera. And one last final thing on policy. I'm sure that many of you know about Representative Lauren Underwood's amazing work, and Senator Durbin and Senator Duckworth supporting, as well as many people across the country, supporting this 12 individual bills that are folded up into the Black Maternal Health Momnibus. And it focuses on things like social determinants of health, community-based organizations funding, women veterans, support diversifying the perinatal workforce, improving data collection processes and quality measures, investing more in maternal mental health care, improving maternal health care and support for incarcerated women, investing in digital tools like telehealth, and promoting innovative payment models to incentivize quality maternity care and continuity of health insurance coverage from pregnancy through labor and delivery up to 1 year postpartum. So in conclusion, racial ethnic inequities just don't happen. When it comes to science and NIH, research has got to aim at addressing root causes. Racism is a risk factor that kills. We see it in maternal mortality. We see it in COVID-19. Racial and ethnic data are important to obtain, and not just to document the inequities, but to provide the appropriate resources according to need. And that includes vaccination resources, healthcare resources, prevention resources, and treatment resources. We have to be willing to commit to change. And it's not just folks like you and me. The highest level leadership needs to be committed, truly committed to change, and transparent and iterative on their reports, on their journey, because this is a journey. This doesn't just end with one piece of legislation. It doesn't end with having all your employees and clinical care staff and front desk staff going through anti-racism training or bias training. We cannot train ourselves out of this out of this pandemic. We cannot train ourselves out of maternal mortality disparities. I guarantee that. We also cannot DEI officer us out of this either. There's just because there's a vice dean of diversity, equity, inclusion, or a chief equity, health equity officer, or anything of that sort, does not mean your institution has addressed inequities adequately. All right, so those are super important parting points. The response has got to be hyper local. We have to leverage community partnerships. More data are needed, good data, not just data. Research needs to include diverse populations of pregnant persons. Look what happened with the initial vaccination studies. They completely excluded, for no reason, pregnant and lactating persons. Interventions and programs are needed to provide explicit, targeted, and centered support of Black, Latinx, and Indigenous pregnant persons. We need leadership at all levels. Health systems and policies should be scrutinized for opportunities to eliminate bias and structural racism, including reimbursement models. We have to unbend the trees or plant new ones. Make good trouble, look under the hood of the car, like John Lewis used to say, and understand and see all of the context and ask why things are structured the way they are, why things are happening right now. The questions are crucial, because if we don't ask the right questions, the output's going to be junk. Empathy, humility, and self-awareness, and opportunity is not evenly distributed. We've earned the distrust of our Black, Indigenous, and Latinx patients, and we have to work even harder to earn that trust. And my final parting statement is that if you're interested in maternal mortality and want to learn more at the national level, Congress, both Senate and House, mandated that the Office of Research and Women's Health at NIH have a consensus conference on 3 topics. One is maternal mortality disparities in this country and research. 2 is research on cervical cancer and why we have not reduced mortality, even though we have Pap tests and HPV screening and vaccination. And 3, chronic debilitating conditions in women. Why aren't we doing well with that in this country? So if you're interested, this conference is free and open to the public, October 20th and 21st. It's 9 to 4:30 p.m., but the main conference is the day of the October 20th, and there's the website there. I encourage you to join. It will be recorded as well. Thank you so much. If you have any questions and want to follow up with me, I'm on all of these modalities, including Twitter, and I have a podcast, Skinny Trees. So thank you. I appreciate the opportunity and the time this Friday afternoon.
Melissa, wow. You went through a lot of information for us. You may want to sort of keep access to your slides, because there may be questions that come up. I thought you had some pretty cool slides. Why don't you put up the slide on kind of equity versus equality? You started out with that.
Sure.
Just talk a little bit, and then there may be others that are good for conversation. And so we only have one question in the Q&A, but I know that more will come. So one of the things that you talked, so I'll start, but I'm going to get to this question because it sort of wraps in. So in Illinois, Dr. Simon, Medicaid actually pays for more than 50% of the births. And so you alluded to reimbursement models as an opportunity to see what we could do to improve some of these outcomes in this particular state. And I just wanted to hear your reaction to what I'm about to say. So Medicaid pays for the butt in the bed. So a woman will come in and deliver, okay? She may have come from somewhere outside of the system. As an example, I'll just use Northwestern. A woman may come there to deliver, but her records are, if she had any prenatal care, it's in a clinic somewhere, it could be on the south side, west side, could be downtown, but she'll show up. And there's sort of multiple levels of things I'm gonna kind of put in front of you, and you can respond to any, all, or none. Mm-hmm. First, and I used to work in the ER, right? And so we've been in the similar places. The doctors and the nurses may, not always, say to her, where are your records? And they'll make her feel really, really bad. She's trying to deliver her baby. And we will, and I've seen this happen, we'll make, where are why are you here? Your records aren't here, your doctor's not here. And so we do that, number one. So Probably the reason her records aren't there is the doctor who she saw doesn't admit to Northwestern, doesn't admit to UFC. They're not on medical staff, and so they're not going to have those types of privileges. So a lot of times a woman will make what I call a rational decision. She'll go to a place that generally does a good job delivering babies and whatnot and to deliver, but her doctor may be somewhere else. And so there's a real disconnect. And we saw this at Next Level Health with our members, right? That's why I know quite a bit about this, and I can follow the claims and I can look at the payment kind of history. The other thing is so let's say they go to a hospital that's not connected to their PCP, they will be discharged, and Melissa, with little to no follow-up. Like, no one is accountable, but everybody will send you a bill. They'll send the payer a bill, and I've seen this at Next Level Health, so I have the data. I'll get a bill from this one, a bill from that one, and then no one is responsible for that. You mentioned a 2-week well check, a 6-week, and then now Illinois passed, hey, we'll follow you for a year. Melissa, who's actually going to be accountable for that transition of care that you described as an opportunity to intervene? Because you just told us that there's a good chunk of the morbidity that happens and mortality happens up to a year out. So any thoughts there?
Whew, is that a good question?
I know it's kind of an answer, but just you can respond a bit, and then we can go to another question.
Absolutely. That's the key. Who is responsible? I think ideally, wherever a pregnant or birthing person receives their care, their longitudinal perinatal care, should feel like that's the place they're going to, and that's the team that's going to care for them, and then that they are connected to whatever the birthing center or hospital is, and that should be the team of responsibility, that initial care team. But you're right, I see this all the time. I see because I myself take OB triage or OB emergency department shifts at Northwestern, and I see it all the time whereby patients come in and they're receiving care from one clinic somewhere in Chicago and said, I want to transfer my care to Northwestern as of today. Or I've always have aimed to give birth here at Northwestern. I just got my care at such and such clinic. Happens all the time. So it's a great question. I think what really needs to happen is all the healthcare members of in the city or in a region have a powwow with a real discussion around what to do, because you're right, somebody's got to take responsibility. And if we are really going to do right, we're going to understand that there's got to be some flexibility in the system, but there's got to be availability of healthcare records. And I know Care Everywhere does not work for all health systems across the city, but there's got to be records so that we don't have to redo all the prenatal labs every time somebody decides to show up in another place, but also for that follow-up up through 1 year. And I don't have a good answer for that, because
Right.
it really,
I want to put on the table with you, because you're interacting in the national sphere, and what we can say is Medicaid spends over $20 billion a year in our state alone, and a nice chunk of that is on delivering babies. And what was clear that happens very well, was very efficient, Melissa, is person ends up, like you said, at Northwestern, they go in and deliver that child, because you guys, you take care of the child, take care of that, you do that. And then if that baby's sick, you have NICU and you send very large bills, right? So what's going on, the billing is great. So when people go get a service, you get a bill. When that baby's sick, you get a bill. And then that woman goes home, and literally nobody, and this is not, I'm not picking on your institution, this is citywide. This isn't a really large issue, that the billing is very, very efficient, but there's zero accountability for that woman's transition, unless that someone happens to call the health plan, because now everyone on Medicaid has a health plan. So the health plans are ready to talk to you, because they want to make sure that mom and that baby are okay. So that's one of the opportunities for us to think about, is that everyone on Medicaid, they have a health plan. And if people would stop to figure that out, we could stand in the gap to help that woman transition home. Hey, you got another question here. I'm aware of one hospital in Chicago that paused its delivery services in the early phases of COVID. If this endangers fetal maternal health, what policy is needed to prevent this in the future? This is Nikki Shields. Thanks, Nikki. So I know that on the South Side, Advocate Trinity and St. Bernard stopped delivering babies right in the middle of COVID. There was a big article in the New York Times where one of the Black OBs was talking about the experience of working in that neighborhood and being under-resourced. I don't know if you have any thoughts there. I mean, this is a big one, right? We're in the middle of a pandemic. We've never been in that sort of space before. And we know that facilities were overwhelmed during COVID. So Melissa, I don't know if you have any thoughts about creative.
So I will say that my preference would have been for no hospital to close down, right? During the pandemic, but for the birthing units. But what's really important to understand, and perhaps this is where the policy lever is that a place like Northwestern, for example, or University of Chicago, we had more resources and staff to accommodate fluctuations in staff availability, to accommodate complex pregnant situations. We had no idea what COVID was going to do during pregnancy, but we had, a relative privilege and a position of resource, both not just money, but resource of people, curbside, and try to figure out, we had infectious disease, pulmonologists, critical care, and obstetricians and maternal fetal medicine specialists, that really we were talking every day. And we were talking with people across the country pretty much every day in real time on how to care for pregnant people who had COVID. And so when that aggregation of so-called brain trust and resource is at some particular institutions and not others, I actually want to see all the pregnant persons across the city just have the ability to get care at those centers until we learned and were able to distribute that knowledge outside and train others, because we were learning in real time. And I actually think there is an advantage to that model, only if, though, this is where the policy is, only if all pregnant and birthing persons could come to those places that had the highest resource of knowledge, of access to equipment, medications, different strategies, and we were in a relative advantaged position of information flow from across the country of other maternal fetal medicine specialists and infectious disease specialists and pregnancy and all other critical care specialists to try to figure out how the heck to care for pregnant people with COVID. And that's kind of a, it's a little controversial comment, response, but at the same time, then the policy is, can you divert patients to the right places during a critical time, and then get that information back out and open up the labor and birthing units in a way with protocols in place that
Right.
will actually be consistent in quality of care with respect to COVID.
Well, and I think, the fact that we've gone through this, and I want to thank everyone for participating today. It's 2:03. If you need to go, we understand. We're going to spend more time conversating. We got questions coming in. So thanks, everybody. So I think that what would have been really cool is if, because we've got such a high infant mortality going on, that we created like a maternal fetal network, Melissa, where what you described going on in your institution could be something that was citywide. And then everybody would know, hey, Advocate Trinity, look, guys, we're overflowing. And I know for a fact, because I actually called them about what this happening. And they said, look, we're overflowing with COVID. We had to bring in a freezer truck to put the dying people into them because the morgue was overflowing. So it definitely was an issue. and just to point this out, there are solutions, right? There are funds. You talked a little bit about, the state of Illinois has put out a health transformation grant proposals, guys. It's a call for best practices, innovation. Maybe one of the innovations, Melissa, could be that we form this maternal fetal network around these morbidity, because I don't feel like everyone in Chicago is talking and addressing some of the real issues, right? So here's another question. You talked about telemedicine and its promises, opportunities. It's relatively new in a lot of ways to all of us, but COVID made us kind of experiment with it. African American women in particular, third trimester, that's when preeclampsia and other rising blood pressure, things like that show up. How it was, do you think about it just from an ethical perspective? If you think about the best evidence that we have, was that the best way to take care of those women? And I'm just thinking about the field and what about OBGYNs and how, what they were thinking. I know everybody was hustling because it was COVID, but we were trying to see women over telemedicine in their third trimester. How are you going to tell if their feet are swollen, as an example?
Yeah, I mean, again, not optimal for some visits, but telehealth actually proved to increase access. We actually showed that there was almost zero no-show rate to telehealth, whether you were publicly insured or privately insured. And so we were at least able to say that telehealth actually does improve a touch point. Now, is it the optimal touch point to ensure all of the potential comorbid conditions are not present? No, but what it did do is at least get us either face-to-face or ear-to-ear via telephone, and get a touch point. Because I think what's really important in perinatal care is that there's continued touch points and there's not a lag where you're not engaging. And so being able to say, doc, my feet are swollen, well, that should trigger, you better come in then. I can't see over the telephone, you better come in. The other thing though, that this telehealth exposed, is that there are inequities in access to home blood pressure cuffs, and that there was only one distribution center across the entire city for people who were pregnant and on public aid, regardless of the plan, that had access to blood pressure cuffs. And the blood pressure cuffs were standard size and not the extra large size that most pregnant women in Chicago need. And so the size was wrong. And to get the bigger size, it cost significantly more amount of money, 160, I believe, dollars. It could have been a little bit more, as opposed to like $30. And so why is the extra large cuff, that's the one that's really needed in pregnancy and immediate postpartum, way more expensive than the regular size cuff? That's just fundamentally ridiculous. And why is it not stocked or available and covered completely for publicly insured women? That was a huge disparity. So the ability to take home blood pressure would have enhanced telehealth significantly. It still can.
Well, I think, Melissa, this is one, if we talk about, well, what can we do? All we need to do is let Medicaid know. Dr. Arvin Goyle is our chief medical officer. An email from you and me, and if there's anyone else on here, Dr. Sullivan's on, Deb Roche is on, we can sign off and say, look, we need you to cover not just skinny people cuffs. We need you to cover in pregnancy, your arm might be swollen because we're all carrying a little bit extra fluid there. Sure. But that's an ask, Melissa. We can make that happen. And I like the idea of really socializing, taking your blood pressure at home. Like, you can take it, right? We don't have to come in to take it. And if you show women the signs they need to look for, then they can escalate. They can say, you know what, I need to go in. And so I think empowering people with simple information, Melissa, like you said, at the first visit, don't tell them everything, right? Yeah. You say, okay, in the second trimester, this is the things we talk about this. If you're having these, right? So I just think there's an opportunity. The other one is, I know that Dr. Lisa Green at Family Christians talked about a citywide almost, not EHR, but just medical record where her images, her recent labs, I can't list the labs, you know the labs, her measures, her blood pressure could be in a place. And if she ended up at Northwestern or ended up at USC or Rush, that she had some information. Here's a question here. Dr. Sullivan, Murtis Sullivan, said she liked the idea of a citywide maternal and child health action group. And so if someone on this call would be so inclined, and I could help you, but I can't take the lead on it. If we could write for a transformation grant that could fund a coordinator for this, we're gonna need some staff to manage it, to manage the convenings, to manage the, sign on. And we could do this, guys, to bring the city together around this issue and to work collaboratively on solutions, right? Of the time. It could be, when it was COVID, we saw what we needed, but we were scrambling. So there was a group of Black doctors on the South Side. We were getting together, trying to educate community, trying to talk about, we talked to Trinity, we called St. Bernard, right? We were doing, but it was all very fragmented. And if we had a collective, I think that could be really positive. So if someone could write me a note, I'm happy to kind of help get that started. And Melissa, I think this would fit nicely into your Center for Health Equity, because so the grant could go to you and you could hire, I'm not trying to give you more work to do, but I'm saying.
No, this is a great idea. I love it. I was worried about the transformation grants, and I thought they had already funded one with doulas and home visits, but I'm not sure. I couldn't find it.
Yeah, so this isn't necessarily doulas and home visits as much as this a citywide, so all action collab. It's action, it's solving problems. It's, hey, what's going on in the city? It's, hey, what have you learned? And what have we learned about COVID and pregnant women? Here's the vaccine, it's coming up on winter. What vaccinations are we recommending? So more people can be brought up to speed. I think, we can talk about that offline though, but if people think it's a good idea, hit us up in the chat and say, I see some folks says that they would help out. Here we got Aisha Akhtar, and a couple, Dr. Sullivan, if you want to work on this, but Melissa, there's millions and millions of dollars. So this could be a $500,000, $1 million grant where we had a series of kind of deliverables. What do we want to get done? And I think the state would be, they are looking for people to try to solve some of these disparate issues with disparities. Deb had a question. I know patients with care elsewhere that print apprentice are assigned to PAC clinic providers. Do they not schedule follow-up? Is it only for the 6 weeks and not beyond?
Yeah. So the patients that come to Prentice and deliver and had care elsewhere, we try to encourage them to go back to their clinic of origin for the postpartum visit. But if they do not want to, they have an option of a postpartum visit with us. After that, we have yet to do, I would say, a better job of continuing them. It really depends on what the comorbid conditions are. If there are none and the patient doesn't want to come back till the following year, then that's fine. But if there's issues of checking in for mental health, we do have a perinatal mental health team, which is really exceptional. It's called the Compass program that will follow patients over time beyond the 6 weeks. They will follow the mental health team. If there's issues of blood pressure or diabetes, we encourage the patients to come back. But again, this is part of the challenge. Part of the challenge is the patients don't come back, and it's not for lack of trying, but it's that lack of connectivity. So if you come and you're coming to Prentice, for example, or a particular hospital to deliver, that's kind of your mindset. Your mindset is, I got my care here for prenatal stuff. I'm going there to get my birth, and then I'm done. We have to kind of shift the mindset of not only healthcare providers, but of pregnant people themselves, that care doesn't stop a few weeks after birth. Care continues, just like you have to bring your baby multiple times once it's born, and through that first year several times. Well, you also have to bring yourself and get cared for as well. We haven't shifted the messaging yet around that, and I think that is part of this process that needs to happen, and that could be part of this collaborative as well. Is how do we change the mindset? How do we get messages that are consistent from all healthcare maternal health care providers across the city to people, to pregnant and birthing persons? And then
Yeah.
how do we get the message consistent out to all the providers, clinicians as well?
And I like that, your work with doulas, when this group convenes, and I see interest from some great colleagues, Melissa, I think we can do something
Wow.
here.
Yeah, wow, look at the chat.
I know, right?
We-
But if this, you and others have worked with doulas, Dr. Sullivan, when she says work from California, New York should be considered. Doc, are you talking about doulas? I don't know exactly what that refers to, but let's say we had a layer where we were either funding more doulas when we saw that this connectivity was not working, that will work with particularly women who are unattached when they come to deliver, to attach them. We need a person that can facilitate that and support the women. So perhaps we build in a doula component to the request. Hey, we got about 8 or 9 weeks, I think, to get that in. So we'll have to convene very soon.
but do that soon. Okay,
yeah.
that's good. We can do it.
Yeah,
if it's not that long, we can do it.
It just dropped. They had a webinar earlier this week, and so I think it was October. I think it's due in December early, but they're looking for great ideas, guys. And so I feel like, man, we got to do something here. There was something here about interoperability and safety nets from Dawn Gay. Dawn, what are you kind of referring to? Want to tell us more? I don't know if you can speak up. I think I have to have a question, but interoperability and safety nets, we'd love to hear about it. So join the convening. We're going to put a thing on the calendar. Then nurses Mary Burns says, nurses may need to be brought up to speed on the best ways to work with doulas to provide best care. Melissa, any experience with that, connecting doulas to nurses? Like, how is that going? Because we put a new person into the ecosystem. If they're not received, then they're not going to have a chance to be effective.
Yeah, I mean, I see it parallel to how we brought in patient navigators and community health workers for other diseases like diabetes. We had community health workers and diabetes, right? And diabetic educators coming on to be embraced as key people of the healthcare team, especially with the connectivity, better connectivity to the patient and their community. Same thing with patient navigation and cancer care delivery. Healthcare provider teams are increasingly recognizing the value of patient navigators and what patient navigators do to help ensure connectivity to the clinical care team for cancer cancer screening follow-up and for treatment. So I think the same thing has to be thought of with respect to doulas being an essential part of supporting a patient through their perinatal care and postpartum trajectory. I think this, again, we have great examples from diabetes and cancer care and other HIV care as well. So why not in pregnancy care?
Absolutely. So how are we doing on time? 2:17. We have some great folks, and what's wonderful is they're coming from all aspects of the city, which is what we want. We got, and Dr. Sullivan is retired, but not really. She's been working the space for a long time. She's a pediatrician.
I love that.
That's right. We have someone from Loyola. Deb is working on a project at Prentice on racial disparity and inequities, as well as leading the education work group with the Northwestern IPOC. Deb, I don't know what that means.
Illinois. That's Illinois Perinatal Quality Collaborative. That's the thing I kept ranting and raving about. Yes, I'm part of that group.
Yeah. Okay. Yeah. I think, and the key is that we're working on solving problems. We want to take off like big old things, but we see opportunities to intervene where we can bring either the members and the people up to speed, or we bring it up the practice of healthcare. And guys, when we see things that are wrong, we got to call it, right? We've got to, and sometimes it's like calling the person, pick up the phone and say, hey, I heard you're doing this. Is that true? And just talk to people, right? I think there's a lot we can learn too about trying to figure out who to talk to and really creating an opportunity for action by providing direction. Sometimes that is. And then Melissa, people wanted you to share your deck. I'm thinking it's proprietary to you, but it is in the recording and people can view it and take pictures of slides. Well, Melissa, I can't tell them to take pictures of your slides, but that's what people do. So,
Yeah, I know that's what people do. Yeah.
so
Took me a long time to put these slides together.
yeah,
I will say that I want to give a shout out to a very important member of the Illinois Perinatal Quality Collaborative that's on, and that's Patty Lee King. She's like Dr. Ann Borda's right-hand person. So she like, you know, is mastermind behind all the great work that they're doing across Illinois. So such a like a local Chicago maternal health collaborative could really nicely dovetail with the Illinois state.
yeah. And
Perinatal
I
quality.
think, you know, this collab could take on, uh, well, we have a desert on the south side, which is really a great place to sort of problem solve. Okay. If you would, you can't, and you can't ignore the fact that Medicaid delivers 51% of the babies. So what is going on in Medicaid, right? And we got to kind of talk about that, right? Like hospitals are billing, then the person leaves, they get a kicker for maternity, they get the NICU baby, they file huge claims and whatnot and get paid big money. But in fact, plus they get hospital assessment dollars, right? So there's dollars coming in from a lot of places when babies are delivered at the hospital site. So there is dollars, but then are the dollars perpetuating the best practice, or are they perpetuating, you know, the one that we have now that's not working? So I do submit to you guys that the system that we have today is the one that created these disparities. So we have to look at the payment models too and really begin to examine where the dollars are going. And so that drives the direction of practice. It sets standard operating procedures, right? So oh, thank you. 50% or more babies live on the south side of Medicaid. Yeah, oh yeah, no, that's me talking. Thanks, Deborah. So are there any other, and I'll work with Deborah to set, I think she has everybody's email who wants to kind of sit in on this kind of initial discussion. We'll create an agenda based on today with the goal of submitting to the state a transformation proposal that gives us some funds to be able to do something. Because we know, Melissa, I know you're doing a lot of stuff, right? So it's like you want to do stuff, like let's get something done. And this is provocative, and many of us are living this, right? We're looking for solutions.
I mean,
So
imagine, I mean, I've been thinking about this for a long time now with respect to, you know, we have the perinatal HIV hotline, right? That's run by Illinois, by Northwestern, whereby all calls around HIV and pregnancy are fielded by us. You know, this whole phone a friend thing is really important, you know, to set up like a collaborative that also allows like you know, in real time curbside, like, hey, this is what's going on. I need just somebody to listen through my plan or what I'm thinking or what this could be. Like, I think if we were able to better connect ourselves to each other across the city, I think we could really help impart a better consistency of and quality of care for every pregnant person.
great. Okay. Well, I want to thank everybody. I want to thank you, Melissa, for staying on a little bit longer to do
Thank
a
you.
Q&A with us.
Thanks for
Uh,
inviting me. I had a lot of
I
fun.
know. It's so great seeing you. And I hope that you will work with us on trying to convene this little group here to get moved towards action. One of our first action items will be thinking about an application to the Medicaid Health Transformation Grants, but then also figuring out how we reach out to health plans to get them to pay for larger size cuffs.
Oh,
And I
yeah.
think they're just not aware, to be honest, and let's make them aware. And so let's try to get what is the low hanging fruit? Let's go after it, you know?
Good. We
And then
got
we
the
can
picture
talk.
of the fruit on the thing.
Exactly. There you go. Um, so thanks, everybody. Thank you, Dr. Simon. The recording will go up soon, probably in another week or so. And we look forward to convening with those of you who are going to be on this work group with us. Thanks,
Thank you.
everybody.